Hi, welcome everyone. Really great to see people joining in. We have we have people joining in slowly, so we're gonna give it some time for everyone to get settled and sign up, and then we will be starting. So yeah, please keep logging in, and while you're doing that, please introduce yourself if you can. Open the chat box, make sure you click on everyone in your response so that your response can be seen by all of us, not just the panelists. And let us know your name and which OHT or organization you're coming from. And that way we will get to know each other better. Please keep plugging in and we'll be starting in a few seconds. Great to see everyone. Again, as you're signing in, please let us know who you are and where you're coming from in the chat box. I see people responding in the chat box. Welcome everyone, and good day. And yeah, throughout to this webinar, please, whenever you're responding, it would be great if you set your chat box response to everyone so that we can all learn from each other. So we're going to give it a few, like 10 more seconds, and then we'll start today's session. So welcome, everyone. And yeah, so I'm Priyanka Gayan, and I'll be one of your hosts today. Before we start, I'd like to begin today's webinar, by acknowledging this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are very, very grateful to have the opportunity to work on this land. So with that, please everyone keep joining in, and we have an incredible bunch of speakers and experts, and we'll be hearing their experience. We'll be learning from them and from each other. So with that, as always, we're going to start with a quick poll. Please let us know if this is your first time with us with an HSPN webinar, or whether you have joined us before. We do get some new audiences every webinar, and which is great. And we do have most of our audience who has joined us before, and it's wonderful to have all of you. So please let us know if this is your first time joining us. I can see responses coming in, which is great. And we'll give it 5 more seconds, and then we can end. And yeah, so, okay, I don't seem to be able to share the results. So Trisha or Nusrat, if you could kindly do that.
Yeah, I think we're
okay. I can see it. Okay,
yeah.
Great. So, okay. So we have, this is great. We have quite a lot of new colleagues joining us today, 41%. It's incredible. And we have 59% who have joined us before. So welcome everyone who is joining us for the first time. Hope you like it. And please check out the webinars we had before. We had quite a lot of contents and resources and recordings of all our previous webinars which you can get access to in HSPN website. And yeah, so welcome everyone. And we have a lot of resources. Feel free to check them out. So for today's session, if you have joined our April session, you might know that we are currently focusing on health equity in the ongoing Little webinar series. In April, we started off with how we can think about equity in integrated care and make changes happen. We also discussed them from a data point of view. Recordings of the session is now available in HSPN website, so you can go back and look at it. This is our second webinar of that same series, focusing on health equity. Today, we will be focusing on capacity building for equity work in the OHTs. We have Dr. Paul Wonka with us today. Paul is a postdoctoral fellow with HSPN, and his work mainly focuses on health equity in integrated care programs. And Paul will be taking us through most of the rest of the webinar today. So without further adu, Paul, over to you.
Yeah. So thank you, everyone. And so this is the second of our four webinar series on the equity in Ontario health teams. And for this presentation, we want to present our other speakers for today. So we're going to have Janelle Austin is a registered social worker with a master's degree in social work from the Toronto Metropolitan University. So Janelle has worked with the community health sector for over 10 years with a special focus on health equity, and is currently the project manager of Anti-Black Racism Initiative at the LAMP Community Health Center. Then for the Central West Ontario Health Team, we have Aju Eluvantigal, who is an equity director and inclusion lead at the Central West Ontario Health Team. And Mirna Adams will also be presenting. So Mirna is a retired community outreach worker and a social service worker focused on gerontology. She had been a resident of Brampton for more than 40 years and is an active member of the community volunteering for the past 29 years with more than 40 organizations. Presently, Mina is the chair and founder of Brampton Museums of African History and Culture, president of the Brampton Senior Council, Citizens Council, Brampton Young at Heart Seniors, and an active member of 13 non-profit organizations. Apart from it provides personal counseling as needed. In 2017, Mina was honored as Ontario Senior of the Year, and in the following year, 2018, recognized in the House of Commons during Women's History Month as an activist having an impact in shaping Canadian society. And in 2021, Mina was also recognized for her leadership and dedicated service in elder abuse prevention by Elder Abuse Prevention Ontario. Mina has, for the past few years, developed and hosted a cultural event, The Many Faces of Canada, Many Cultures, Many Rhythms, One Heart, a successful and inclusive event celebrating the diversity of the country, in particular the region of Peel, as an annual event, bringing people together to work in harmony, celebrating the many differences and commonalities with the understanding that people have a desire for the same things: acceptance, well-being, security, esteem, equity, and fulfillment. Mina continues to look for innovative ways to improve the quality of life of all Brampton residents. Mina lives by the motto, as espoused by Nelson Mandela: there can be no greater gift than that of giving one's time and energy to help others without expecting anything in return. So we have a really wonderful list of panelists here who are ready to present their experiences in terms of their journeys through which their OHTs went through in building capacity for carry out equity work. So that being said, I will start by running the second poll, trying to have a sense of what kinds of resources and infrastructure that you have had to use to support equity work of your specific OHTs. So we would want to know, if you have had any specific activities that are related to equity yet, if like you have mobilized resources to establish equity work groups or committees, or if you have already established equity work groups and committees around in your OHTs, and if your OHT is actually supporting other OHTs to establish equity work groups and committees. So we would really want to hear from you just to let us know exactly from this poll if you have any of this that is actually going on. So now I need to get this poll data. No, I don't have it yet. Yeah. Okay. Oh, okay. Yeah. So, oh, this is really interesting. So, so my understanding is like most OHTs are actually kind of like in the middle, like about 17% of OHTs have not yet started any specific activity related to equity. So this is going to be really interesting to listen to the stories of our presenters that have been going through different growth pains and challenges and opportunities to actually advance their equity work. Then about 39% of our respondents are mobilizing resources to establish equity work groups, and also about 31% have already established different like work groups or committees. And then, oh, this is so interesting, about 8% of OHTs have really gone as far as working across their OHT boundaries with other OHTs in order to strengthen their equity capacity. So just by checking in the chat, okay, so I think there's Leslie that says the Ottawa Health seems that they have like an equity charter that have expectation that OHTs have a strong focus on addressing health equities. Then Mike, okay. So, okay, so thank you for responding to this poll. So we will just start now directly with our presentation. So the first presentation, we'll start now by the overall background of Ontario Health Teams is like following the Connecting Care Act of 2019. The government of Ontario introduced Ontario Health Teams as a collaborative care model that enhanced collaborations between various partner organizations, including hospitals, primary care, community organizations, to provide more connected patient-centered care to the populations of their catchment area. So these healthcare reforms require changes in the way partner organizations work together, such as establishing collaborative governance structures, also promoting virtual care, establishing shared resources, and different kinds of evaluation models in order to advance in their collaborative work. And a key component of the reforms was to advance equity in Ontario Health Teams, specifically ministerial guidance documents and recent Ontario Health business plans explicitly show the commitment of senior leadership to advancing social justice and fairness in all aspects of the structures, the operations, as well as the outcomes of Ontario Health Teams. In fact, Ontario Health Teams have to modify or change certain aspects of the way they currently work in order to effectively promote equity-oriented practices. So this webinar focuses on how Ontario Health Teams have built capacity to carry out their equity work. And a useful way of thinking about this is from an organizational change or implementation science perspective. So the Health Equity Implementation Framework is a synthesis of international literature that highlights key factors that influence the way health systems around the world implements equity in their organizational practices, or also like in their wider healthcare system. So as we look at the different layers of this framework, we start with the external, like the most exterior layer, that is the societal factors such as the socio-political forces, economies, or physical structures. So, for example, in our Canadian context, we can think of things like the legacy of colonialism or current discriminatory practices against marginalized groups. that can hinder their participation, especially at senior levels of decision making in health-related issues. So this can actually have an impact on the way they this health system to build capacity to carry out their health equity work. Now, we can also look at the second concentric layer, that is at the organizational level. So they are factors such as the priorities of the different organizations, the commitment of senior leadership to actually carrying out the equity work, or we can have other factors like inter-organizational networks and the relationships between the different partner organizations within these inter-organizational networks. So as we're going through this journey, we can see some organizations, for example, like hospitals that might have had pre-existing equity groups, and other organizations, smaller organizations that probably didn't have that. The way they actually come together to work is going to actually influence the way they carry out their equity work. So some other organizational characteristics, such as the location of the organization, be it an urban or in the rural area, or the distribution of resources, may actually affect the way equity work is carried out within the organization. So finally, this framework also highlights cultural relevant factors of patients, providers, and also of the innovation. So we can actually think of things like values and beliefs of healthcare providers that may affect the way they behave during patients provider clinical encounters, that actually affect the way the organization carries out its equity work. So overall, this framework, it's useful. It gives like a very long, I wouldn't say comprehensive list, but like a lot of factors that can potentially affect the way equity work is carried out or implemented within a health system or organization. And no one organization will actually have all of these factors together. So this framework that actually emanates from an extensive literature synthesis might be a helpful way that OHS can actually use to identify different uh, factors that might actually impede or advance the way equity work is carried out within their own OHTs. So what does this mean for Ontario health teams? So in terms of Ontario health teams, we can think about, like, as this Ontario health teams evolve towards maturities, they might have to carry out incremental changes that aim to strengthen equity-oriented work in their inter-organizational network. And these OHTs may need to develop clear guidance documents, frameworks, and work plans that are relevant to their local context in order to carry out their equity work. They may also need to designate a core group of actors, such as an equity work group or committee, that is responsible for establishing these equity-oriented goals and processes to achieving these goals. Then also, it might be important to focus on how to mobilize appropriate human, material, and financial resources to advance OHT equity-oriented work. And finally, this also needs to focus on how you can invest in continuous quality improvement to assess the advancements of your equity work and to adjust organizational practices in order to sustain this work over time. Having looked at international literature, now we want to hear stories from the field. We want to really get a sense of what is actually happening in our Ontario health teams as we speak. So we are going to have speakers from the Mississauga and West Toronto Ontario health teams and the Central West Ontario health teams, so that actually carrying out this equity work. They shall share their journey in building capacity for equity-oriented work, with emphasis on challenges that they encountered and contextual factors that enabled their work. So we will also encourage you to share your experiences in the chat as our presenters share their stories. So we will start with Janelle. So Janelle, you can take over.
Thank you, Paul. Hello, everyone. It's great to be here. My name is Janelle Austin. My pronouns are she and her, and I'm the project manager of Combating Anti-Black Racism Initiatives based in the LAMP Community Health Center, which is a member of both the Mississauga and West Toronto, Ontario health teams. And I'm really excited to be able to take this opportunity to share our story with you and talk about how we collaboratively have approached anti-Black racism. Next slide.
There you go.
Thank you. So as I mentioned, we're going to be talking about the ways that Mississauga and West Toronto have worked together, collaborated to address ABR within our communities. This presentation is designed to just be an example of the power of collaboration. And I'm going to walk you through the journey of our collaborative approach and talk about how this has come to be, what we've done so far, and what we plan to do next. And I really hope that folks walk away with a message that's not focused on the specifics of what we did, but rather on the impact of our collaboration and sharing resources. And if there's anything that we've learned along this journey, and if there's anything I hope to illustrate to you today, it's that it's important to just start somewhere, and that working together often is the best way to go. Next slide. So this presentation focuses on the work being done by the ABR OHT working group, which is a joint effort between the Mississauga and West Toronto, Ontario health teams. Mississauga became the first OHT in the province in November of 2019, and they're comprised of over 90 member organizations representing primary health care, community care, home care, long-term care, social services, and other community organizations. And the West Toronto OHT was approved by the Ministry of Health in November of 2020, and as of June 2022 was comprised of 35 member organizations that work in partnership with patients, families, caregivers, and primary care representatives to deliver a comprehensive set of services. Next slide. So I also want to quickly acknowledge that there are staff from the 4 organizations shown on screen participating in the work being done, in addition to folks from the OHTs. So I want to name Trillium Health Partners, Services and Housing in the province, Dorothy Lee Hospice, and the LAMP Community Health Center, which is where I work. And we're all members of the ABR working group. Next slide. So these OHTs, for some context, were located as shown on screen, and we cover land that is the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Huron-Wendat, the Chippewa, the Ojibwe peoples, the Métis, the Haudenosaunee, and the Wendat peoples. And we're also existing on land that's covered by Treaty 13 with the Mississaugas of the Credit and the Williams Treaty signed with the Mississaugas and the Chippewa bands. Next slide. So I'm here to tell you a story, and so far I've outlined the main characters. So I want to talk a little bit more about the setting to provide some context and also give you an idea of why the work we do is important. So according to the 2021 census data, the Black population represents the 3rd largest visible minority groups in the cities of Toronto and Mississauga, following the South Asian and Chinese communities in both cities. And this mirrors the trend across Ontario. So the Black population also comprises the 3rd largest visible minority group in the province, as well as across the country. Next slide. So the map on the lower left-hand corner showcases the distribution of the Black population in Toronto based on neighborhood, and the map on the right showcases the overall racialized population in Mississauga. So keep these maps in mind. We're going to come back to them in a short moment. As you can see, though, from these maps, there is a moderate population of Black and racialized folks in both areas, and in a moment you will understand why this is such an important area of focus for us. Next slide. So every good story has a problem, and ours is no different. And in this case, the problem is quite a big one. It's anti-Black racism, which can be defined as policies and practices rooted in Canadian institutions such as education, healthcare, and justice, institutions that we work with and work for. And these institutions mirror and reinforce beliefs, attitudes, prejudice, stereotypes, and/or discrimination towards people of Black African descent. And this has historically been a problem within Canada Canada. The question really is whether or not we choose to acknowledge it. Anti-Black racism is woven into the fabric of our society, and it lies at the heart of the systems and institutions that we interact with on a daily basis. And studies show that racism can cause frequent stress on the body and trigger coping behaviors that often lead to illness and death. In the GTA, Black Canadians often face service deserts, so a lack of safe, inexpensive, and effective healthcare and community service in their communities. And we also know that more recently, race and racism, specifically anti-Black racism, has been identified as a social determinant of health for Black Canadians. As with all movements toward change, this problem in existence has been here for centuries, but there's often a catalyst that sparks action to resolve the main problem. Next slide. So for us, that catalyst was the pandemic. And just to be very clear, it's not that our attention was called to these issues because of the pandemic, but rather the pandemic illustrated the issues we were seeing all along in a way that was undeniable. What Mississauga and West Toronto did was take advantage of the opportunity that was before us to address the needs of the Black community at a time when others were finally ready to listen. Historically, Black communities have been marginalized across Canada. We know that Black communities have unequal access to resources such as medical and mental health care, housing, education, employment, and food. And the Black community is also overrepresented in systems such as policing and the criminal justice system, children's aid, and so on. And the pandemic highlighted those disparities to care and resources even further. So many of us will remember that at the beginning of the pandemic, the narrative of we're all in this together was quite quickly dispelled for those of us who were working directly with communities. It was very clear to us that all groups that had been marginalized were experiencing the impact of the pandemic quite differently compared to those who were not. And while we didn't have statistics, the studies that have and are still coming out back up what we already knew. Black communities were amongst the most severely and significantly impacted by COVID-19. So we know that infection rates for the Black community were 3 times higher than of the white population in Toronto. We know that racialized Torontonians account for 77% of all COVID cases and 79% of hospitalizations. And public health data shows that the Black communities were the hardest hit in the first wave of the pandemic, so peaking about 33% of total monthly cases in August of 2020. And we also know that when factoring in the social determinants of health, the Black community faces challenges in gaining and accessing secure employment, and being precariously housed put them at further risk of exposure to COVID. Also, in terms of housing, Black communities are overrepresented in inaffordable housing. Black households also have an increased rate of food insecurity compared to non-Black and white households. And also Black communities are statistically overrepresented in the low income category. Next slide. So coming back quickly to the maps that I shared earlier, taking a look at the distribution of the population and comparing that to COVID cases by neighborhood, we can see that within Toronto, these maps currently illustrate Toronto, and within Toronto, the areas that were hit hardest by COVID are the areas where the Black community lives. And next slide. We can see that this is also similarly mirrored in Mississauga, with the COVID hotspots being almost identical to the areas where the racialized population lives. Next slide. So in response to this, the Ontario Health Team, or OHT, ABR working group was formed, and this group is responsible for the work that I'm about to outline. This table of individuals exists to support and guide the development of a framework to address anti-Black racism within organizations and communities that are a part of these 2 OHTs. And the roles and responsibilities of this group are to build capacity in addressing anti-Black racism within these 2 OHTs by supporting member organizations with the following. So firstly, to organize equity and anti-Black racism training sessions, to create opportunities for collaboration between the OHTs, to identify knowledge sharing opportunities, to provide direct and short-term support to partners who have completed the organizational self-assessment survey, which I'm going to speak further to in a minute. And for these organizations, the support we're offering is to create and implement action plans based on the results of this survey, to identify and access training and education opportunities, as well as to access tools and resources. We're also focused on conducting community-based research, which will understand the needs of the Black community, specifically in relation to mental health. And we're also tasked with identifying actionable strategies to better health outcomes for the Black community, which is in line with work already existing in relation to anti-Black racism. Now, I am jumping ahead a little bit. The group didn't start off with all of this, so I'm going to rewind a little bit to when the work began. Next slide. So I want to acknowledge the contributions of the folks who supported the working group at its inception. So before I share the timeline of events, I want to acknowledge these 6 individuals who are responsible for laying the groundwork for the work that we're doing right now. Next slide. So our work first started in December 2020 with an opportunity to apply for a federal grant to support ABR work in Toronto. And the decision to collaborate was made given that organizations within Mississauga and West Toronto OHTs already are working closely together for various aspects of this work, and we're collaborating specifically in regards to health equity. So it was thought that this work could be done together instead of reinventing the wheel. The underlying principle behind all of this was that anti-Black racism and equity work can go further and it can go faster when more people are collaborating and working together. It can be difficult to know where to go with this work, and one of the best things to do is start with assessing where you're at. And for this reason, the MOHT and West Toronto OHT pooled funding to validate an existing self-assessment organizational survey. And this tool was designed to support health and social service organizations with identifying their current state, their capacity, and opportunities to meaningfully address anti-Black racism. This was a significant undertaking by this group, and it enabled organizations to situate themselves within the context of their ABR work. The survey was updated in partnership with the Institute for Better Health, or IBH, which is a research institute affiliated with Trillium Health Partners. At the same time, the group is already collaborating to provide leadership education on health equity, understanding that knowledge sharing is a key aspect of the foundation of any health equity work. So not necessarily waiting until the survey results were out to do this aspect of the work. In order to provide both of these opportunities, again, the 2 Ontario health teams pooled their resources, which includes time and funds, to make this possible. And all of that work led to spring 2022, when things really started to gain traction and pick up. So the survey was implemented at this point, and it's remained open for a month from April to May 2022. We had a total of 20 organizations participating in this, and a total of 617 responses received. And the results were compiled and analyzed by the Institute for Better Health, which was possible through the pooled funding between the 2 OHTs. We were also able to compare the results and the responses across both OHTs because the survey was done collaboratively, and we realized that the results aligned and they were quite similar across both OHTs. So staff were highlighting gaps in various areas, which included recruitment and retention, organizational commitment to anti-Black racism, gaps in meaningful support offered and available to staff, as well as gaps in knowledge and information sharing. So the survey highlighted key areas for growth and work. They're currently being implemented, and based on these results, there were 3 commitments that the ABR OHT working group made. Next slide. So in November of 2022, these 3 action items listed were presented to both OHTs, and we're continuing to work towards these items today. So the first action item was to hire a project lead, which is my current role. And I'm responsible for supporting the ABR work done by member organizations, and primarily those who have completed the survey. And I'll speak to those responsibilities a bit more in a moment. The second action item that was highlighted was an opportunity to facilitate a shared collaborative repository of resources around ABR. And while these repositories exist out there, we're not looking to reinvent the wheel. We are considering how to make those resources easily accessible, affordable, and available to our members. And the final action item presented was that we would be creating training opportunities for OHT members that focus more on actioning change within the OHTs. And this was already partially underway at this point in partnership with the COJO Institute. Next slide. So coming back to our timeline, in the spring/fall of 2022, the equity and anti-Black racism training sessions that were already underway in fall of 2021 were offered to OHT members, with a combined total of 153 participants attending 4 sessions. And these sessions, which were offered by the COJO Institute, enabled participants to learn about and discuss health equity through an ABR lens. And we've been able to make those recordings available to our member organizations. And currently, through the funds that the OHT working group has received for my position, they're using this role strategically to establish various aspects of our work. And we're focused on a few things in expansion from what was committed to back in November. Next slide. So firstly, we're looking to provide hands-on opportunities for learning and knowledge sharing, and we're doing this in a couple of ways. My role is designed to offer one-on-one support to organizations who've completed the self-assessment. And this role is designed to provide expertise in areas such as creating and implementing action plans, accessing training and educational resources that are specific to the needs of each organization, as well as facilitating collaboration between OHT members. So really maintaining this collaborative approach. I will also be taking on responsibility for research, which I will mention in a couple minutes. We're also in the process of gathering a network of agencies within the OHTs to create what we're calling a learning network. And this is designed for us to learn from one another and share knowledge and expertise specifically related to anti-Black racism. And we are working on creating further training and learning opportunities, including an exciting new ABR training series that we have been able to make available to member organizations through funding from the OHTs at no cost to the members of the OHT. So it's another benefit of this collaboration. Secondly, we're committing to increasing access through resources, and this is done through a few ways. The aforementioned repository of resources, the training that I just mentioned, as well as developing and accessing policies. And finally, we'll be conducting research to support program and service delivery. And this will be done through further collaboration with Humber College's Center for Innovation and Health and Wellness. We're at the beginning stages of refining the research question and identifying a specific area of focus, but we are looking to conduct community-based research that will have a broad impact on member organizations of these OHTs. And then finally, we're looking to continue to share our learning and our work on anti-Black racism with broader OHTs through avenues such as this one. Next slide. So as I wrap up, and in summary, the impact of our collective work in addressing ABR is so much wider than it would have been if we had not decided to work together. The opportunities would have still been available, but it would not have been possible to take advantage of these opportunities at the level that we have if we decided to work separately. And by choosing not to compete for resources and instead to collaborate to serve Black communities, we have been able to increase the impact of the work being done to the combined 125 plus members of both OHTs. We do know that collaboration can be challenging. However, in line with this health equity implementation foundation, it's very clear to us that pulling together our resources and supporting one another makes it possible for us to go much further than we could if we were trying to do this alone. And while the work isn't done yet and the resulting impact of this work is yet to be seen, we're really excited to continue to collaborate to tackle this important health equity work together. So as I close, just want to say thank you to folks for taking the time to listen to our story. And the story is not yet finished, and we look forward to uncovering the ending collaboratively.
Yes.
Thank you.
Yes, thank you everyone thank you Janelle for presenting, and we will have questions at the end of the next presentation, so in about 20 minutes. So if you have questions, please just put them in the chat. If you have other experiences that you want to share which are in line with Mrs. Yaga Ontario Health Team's experiences, so please just put them in the chat. So we would like to hear from you. So next we will have Mirna is going to start presenting for the Central West Ontario Health Team, followed by Aju. So Mirna.
I'm not able to.
Yes. Yes, Mirna.
Yes. Okay.
Okay.
I'm not able to do the video. It tells me that. Oh,
No,
okay. Now.
Yeah,
right.
it's okay. Yeah.
Oh.
There you go.
Well, good morning, everyone, and I'm just astounded by the first presenter. So that was all very interesting and certainly very inspirational. My name is Myrna Adams, and I'm a member of the Central West Ontario Health Team. I guess we could bring up the slide. I'm going to talk about our timeline, where, why, and when we started. So next slide, please. Okay. So as a result of social justice movements such as the Black Lives Matter, the need for equity, diversity, and inclusion was highlighted across all facets of society. We at Central West held many meetings, both formal and informal, and we also connected with community leaders. We were the first actually to reach outside of our own to work with other leaders to be able to enhance and strengthen our EDIAC. From a healthcare perspective, lack of equity translates to higher costs when we exclude particular populations, decrease access, increase barriers, provide subpar care, resulting in those people utilizing healthcare dollars at a much higher rate. In November of 2020, we developed our terms of reference, and EDIAC was officially constituted. Brampton became the focal point of the pandemic. Brampton is a highly racialized community, so therefore it did become that focal point, creating many barriers, lots of certain pushback and information that we collected that allowed us to move forward to be able to do actually present so that we could do much better for our Black and racialized communities. In May of 2021 to July 2021, equity was identified as a priority through consultations through the scientist groups. It was established that we required a person, a resource dedicated to move EDIAC forward. This was a very important step. We were able to hire a consultant The consultant actually developed a program of 4 sessions, 3 hours each on anti-Black racism. The program was certainly attended. We did have a lot of pushback, but we were able to move past that. We were able to come together, and as a result, there have been many areas where now we do see some changes where that training has made a great impact. I'm sorry, I'm sort of rambling on here. I'm used to being able to talk to people like one-on-one. But anyway, one of our approaches was that we should be more integrated, fully integrated into the work and all it does to make EDI a core part of the Central West Ontario Health Team, organizations, organizational culture, and identity. To ensure success, we developed this action plan to oversee our efforts. It was developed with our Central West OHT committees, working groups, and external stakeholders. We have developed an action plan which identifies strategies and management action, demonstrating that institutional commitment to addressing the historic structural barriers to equity, inclusion, and diversity in Canada. A map modality that establishes an accountability structure to resolve complex issues within EDI domains, to set new accountability measures for the Central West Ontario Health Team. Management actions are designed to create new approaches to concretely measure and report on EDI issues as they are implemented without creating parallel work streams. One of the things that I have found, I mean, this is, I've worked with many groups, organizations, and within the Black community, we have actually tried on many occasions prior to actually have equity for all. But, you know, there are things that precipitate action toward this, but then it stops. This time, it really is very different. There have been, because of all the consultations with us and with our external partners, that there have been equity offices that have been opened and other areas that have been developed to address the inequities within the Black community. Also, I want to say this because many of us are fearful, or Black people are fearful, that once again, this will be something that we will have started, but will not actually see the desired results that we are longing for. However, this is a very different time, and we have, with so many different groups, collaborated. We have made great inroads, and I expect that with all that the work that has been done, with all the partnerships that we have developed, that we will be able to go on and see in a near future the impact of equity and diversity and inclusion. I will not go on much longer because I know that Edu has many things that he wants to discuss. So with that, I'm going to turn it over to Edu, but I do thank you for taking the time to listen.
Thanks, Mana. Thank you for taking us through that entire journey and focusing on the milestones that Central West OHT was able to probably achieve at different stages. And what I would like to contribute to this slide is that while Mona had went through the journey it was more linear. The slide looks very, very linear, but it has been an effort of champions like Myrna, who is part of our Equity, Diversity, Inclusion Advisory Council, who has been able to transform this right from the inception stage till the stage that we have reached over here. And she has been a strong advocate who has taken us till this point. And we continue to have support from leaders like her, who form the EDIAC and continue counseling the Collaboration Council, which is our highest body, to take this journey forward. Just want to highlight that it's not linear. It's been an ongoing process. There are sometimes 2 steps forward, 1 step back, or sometimes 2 steps forward and 4 steps back. So that's the reason you see that like the milestones have been pretty spread out, but there's been a lot of work going on with people like Myrna leading from the front and advocating for equity work. If you may move to the next slide, please. Thanks. So what we'll be trying to focus over here in the part that I'm talking about is how we try to ensure that EDI work was structurally created and how we were trying to actually ingrain it into the working work of the OHT. And that's what I will try to focus on in terms of the engagement. Next slide, please. So when the Central West OHT identified equity as one of the strategic priorities that they want to move ahead, they had defined that we needed to start with the terms of reference. They constituted the EDIAC. They got in a resource, which was me, and they had like a clear-cut ideology in terms of how they want to move forward. So one of the key things that they did was establish an EDI framework, which was adopted from the existing resources out there, including the Ontario Health EDI framework that exists, and like the other frameworks with the hospital, William Osler Health System, Trillium Partners, and we came up with that framework, and then they had the EDI charter. But the key was to ensure that once we have these foundational pieces, how do we go ahead with this? So when we reached out with the EDI framework, everybody was keen to know, it's great to have a framework, but how do we practically implement this? That's when the EDIAC and other members identified the health equity impact assessment as the tool that the Central West OHT would use to ensure that we are able to embed the activities with an EDI lens. And that has been something that the Central West OHT has been utilizing to take the work forward. And we went about engagement at different tables. The experiences at different tables have been sometimes very dramatically different and sometimes have followed similar paths. So I'll talk about a few examples over here. The scope group, we had an opportunity to engage with them, present our framework, present the EDI charter, present the health equity impact assessment tool. They had a lot of questions. They came back to the Equity, Diversity, Inclusion Advisory Council. They spoke at length. We had a couple of discussions. And I remember like there were some specific questions related to how scope would focus on the patient journey or like highlight what patients feel. And this scope program is specifically a program that is utilized by primary care providers, that they are the end users. It's not exactly the community. Like whether through scope is a program that primary care providers can reach out for fast tracking diagnostics and imaging processes, or if they need additional support to consultants. So it's the prerogative of the primary care providers. So there was very minimal scope to ensure that we were taking feedback from the patients because there was no mechanism over there. And one of the feedbacks from the EDIAC was to ensure that at some level we are able to capture that, and scope is working on that because it's not a directly correlated in terms of bringing that DEI lens over here. Priority population is another example. I've dedicated an entire slide to that. I'll be talking about that in the next slide, but it is almost 18 months of work that we had with priority population. Governance is an example where we had a very, very different experience. We presented our framework to the governance working group, working committee, sorry. And we had the framework, we had the health equity impact assessment, we answered questions, what they had in mind, and then there was a discussion. And what happened after that was static silence for a long, long time. But what we need to realize is sometimes the work that is actually happening is like when we present the opportunity to use tools, there is work really happening in the background. And one of the key results that directly came up at a later stage was the fact that the EDAC at inception was an equity, diversity, inclusion action committee. But from there, the governance really worked towards constantly in terms of developing it. And today, the Equity, Diversity, Inclusion Action Committee has been established as an advisory council. It is one among the 3 advisory councils to the Collaboration Council. And that's been a fundamental change in terms of how this work is proceeding within the Central West OHT. It kind of gives you where the leadership sees equity, diversity, and inclusion work, and the need to engage further and prioritizing the EDI work in what they do. The Collaborative Quality Improvement Plan group have focused on multiple things. We had the opportunity to engage with them. They had the opportunity to come to the EDIAC, present their work, get feedback, go back. I'll just like to highlight one of the key areas where they're focusing on, like, because I cannot go on every aspect of it, but we have like a cancer, one group within the Collaborative Quality Improvement Plan, which is focused on cancer screening. They have today come together. The 3 organizations have collaborated together. They are defining which areas to specifically focus, and they have taken an India lens on that. We have high priority community strategy groups, organizations that are focused on that, which are highlighting, taking the EDI lens and very specifically focusing on communities to take this forward. So these have been engagement processes over a period of time, maybe not necessarily linear. There are different opportunities that present, and then sometimes things might seem static, but there is movement that's happening. There are undercurrents that are happening. And what I would like to say is the role of leadership in this is very, very crucial, whether it's the people who are sitting at the EDIAC or the people who are actually engaging with other leaders within the OHT, and the different organizations that the OHT collaborates with. So that has a huge impact in terms of how the results finally pan out. One more example is the communications team within the organization at the OHT itself. We had different opportunities where the team really came and presented the different communications that we have. So the communications team really consults with the Patient Family Advisory Council and the Equity, Diversity, Inclusion Advisory Council to ensure that we are able to present to the community what we are really trying to do and present it in a manner which is accessible. One of the highlights that EDIAC had provided in terms of its recommendation was being AODA compliant. There has been a strong change in terms of how we have been striving to become AODA compliant. It's still work in progress, and the journey continues. Another set of group that I would like to highlight over here is the OHT partners in terms of the health equity journey that they had. So as we identified the health equity impact assessment, I do remember that simultaneously there has been an impetus, a focus from the Ontario Health in terms of getting the health equity impact assessment as a focal point. And I do know that as on today, if you are submitting an Ontario Health proposal for any funding opportunity, they mandate the health equity impact assessment to be completed to take that forward. So we've had opportunities to work with some of our partners, one of them being William Osler Health Systems, specifically for their remote monitoring program for in respiratory care, where they wanted to bring that about. Virtual urgent care had another proposal, where we had the opportunity to work with them in terms of the completing the health equity impact assessment. Another partner, Keynes, who was focused on bringing in more alternative level care beds and ensuring that they ease out the ALC beds strain that is there within our catchment area. We had opportunities to work with all of them. Something that I would like to highlight is it's not happening in the most ideal way at this point of time, where we have these partners probably coming in terms of the stress of budgets and the timelines that they have in terms of turning around a proposal. They probably co-design the whole proposal and then they reach out to us in terms of taking forward this process. But I would say this is step one, and we still have an opportunity to engage when we are going through the health equity impact assessment to provide recommendations and the top leadership to really look into it in terms of understanding and scoping the project, even though they have completed the process initially. But it's still an opportunity where those ideas are implanted, and I would still take it as a win when we are getting these opportunities. If you could move to the next slide, please. So the priority population, which was mentioned on the previous slide, but I really wanted to highlight this story over here very specifically. This journey of the priority population in terms of, this is our priority population, the older adults experiencing frailty, was identified by the Central West OHT 18 months back. They constituted a working group then to come forth with a strategy, a solution to have an impact within this community and really help the community to take this forward. It is an 18-month long journey where they went through an engagement process, identified the causes, took up an population health management approach. They have engaged with RISE at multiple opportunities. I see there are some coaches from RISE over here. They would know that they were part of this journey as we were trying to take this forward. And as the health equity lead over here, I had the opportunity to engage with this working group. I had the opportunity to present the framework. I had the opportunity to bring forth the health equity impact assessment tool, and had a constant engagement with the co-chairs, with the working group ongoing. Like, it wasn't really just the presentation of a framework and the health equity impact assessment, but it was an ongoing engagement. It was an opportunity to keep socializing the concept of health equity and taking on that lens to ensure that we have a very robust program. And the results, I would like to focus first. As on today, we have a pilot phase that has been launched, and the program is already taking in patients on a pilot basis. And one of the eligibility criteria includes social determinants of health, and they have included this as part of the frailty screening itself. So as part of the frailty screening, normally they have cognitive, physical, and medical conditions that are considered to be part of any program for frailty. But the Central West OHT care program, focusing on older adults experiencing frailty, has included social determinants of health like social isolation, food security, to be part of their initial frailty screening, which means that if a patient would qualify for this program, if they have like one cognitive, one physical issue, or maybe 3 out of those, and if one of them is a social determinant of health, they still qualify for this program. And that has been a huge game changer in terms of how we look at supporting the older adults experiencing frailty. And I call this really a success story, because not just because of what you see on the screen over here, but also because of inputs that have started coming in terms of how the clinicians are recognizing the fact that those who would not have been part of this program had social determinants of health not been reported. And if you're not measuring that, and including the patients within this program, there would have been patients that would have landed up directly at the emergency room because of the lack of care and the slip that they would have within the system. So as I move to the next point, which is evaluation, we have also included an EDI indicator. We just have one EDI indicator at this stage because this is a pilot phase, and we'll be reviewing, the evaluation team would be reviewing this when it becomes a larger program, and probably include more EDI indicators. Currently, the EDI indicator that has been recommended is measuring how many patients are being part of this program because they have a social determinant of health influence within the frailty factor. And that's something that we feel that we will be able to highlight very strongly as we go forward and make this really a key program within the Central West OHT. One of the areas that the EDAC has always focused on was the equity-based data collection. And this is one thing we have very strongly achieved through this program. We are collecting social demographic data right at the intake. And so that's the success part of it. Now I want to focus on the challenges that we had and the way this journey went ahead. As I said, it was an 18-month long story. The story still continues. The journey is still ongoing. It wasn't like we presented the framework, we presented the health equity impact assessment, and everything worked. So for full transparency, I need to let you know that this is one program where we have not done the health equity impact assessment, but still we see the results. And the results are because of constant engagement, constant socialization, and sometimes the leadership really coming forward and providing strong support. I realize that one of the key partners to implement this program is also a leader who's part of the EDAC, and that really helps us because they bring forth that view. And it's not an independent journey. Like I remember like a little earlier, Mona was sharing that we had 4 training sessions, 3 hours long each for our leadership. And there were, the way we had planned the sessions, we chose to slightly deviate from those sessions because there was so much sharing over there. The sessions were so intense, but the result has been that leaders across the OHT have identified this as a key criteria in terms of taking forward our OHT work and establishing this very much at a fundamental level, that any program that is coming out of the Central West OHT or being defined or co-designed at the Central West OHT will have this equity focus in taking this forward. So it's not exactly just a straightforward engagement that has resulted in these 3 success that I highlight over here, but it is really the overall journey that the Central West OHT has gone through in bringing this over here. If you may move to the next slide, please. So I would like to share some learnings and challenges. I'm focusing more on learnings, patience, and persistence. As I said, throughout the journey, whatever we have done, there are times when we have faced a lot of pushback, and pushback is not always very straightforward. Pushback, no one really comes to us and tells us, we do not want to do health equity work or equity, diversity, or inclusion work. We don't want to do this. No one is going to say that, but it's the nature of questioning that happens where some roadblocks are created. But I understand that leader engagement and education really helps take our cause forward. Providing relevant data helps to take this forward. Repeatedly engaging with them, and sometimes engagement means going to the meetings. Sometimes it means being part of the meetings, but not really presenting it every time, but being patient enough to have the opportunity to bring it on when it really matters. And the real success happens when, like, the person designated to bring up the EDI work doesn't really have to speak. Like, there are other members on that working group or working committee or the subcommittee who are really speaking up and bringing forth that lens. And that's something that I would say we are very, very proud of now, that engagement has happened. There have been certain focal points which has resulted in this, but that's beginning to show up very, very clearly across different tables. And a highlight has been a strategic planning process that the Central West OHT has been taking up. And I'm very confident that it's been showing up over there. The different leaders are speaking up. It's not the EDAC chair or the EDI lead or a member of the EDAC committee who's bringing it up, but it's different leaders across the spectrum of the Central West OHT collaboration who have been bringing up the EDI work over here. The next point is fluid approach. We might have a plan, we might have a process. We want to do it in a particular way, but it doesn't really work that way. Priority population engagement is one of the key examples. Like, I was pushing very hard, the EDAC was pushing very hard for the health equity impact assessment as a tool to be engaged. didn't happen that way, but what we realized is over a period of time, the approach was different, but the results did come through towards the end. We had to push, we had to advocate, we had to bring in the leadership to talk to people, but it does happen. Changes, we have to be flexible about how we go. And strong leadership, as I have mentioned multiple times, leadership plays a very, very critical role in taking this forward. We've had very strong supporters, strong advocates, and I feel like most of the EDIAC is always in an advocacy mode to get this point across. Socializing the concept, it's not just engagement, but having the opportunity to sometimes just socialize, let it out there, and then reap the benefits at a later point of time. And this is always work in progress, and we keep striving. We have created an action plan over here, and we continue to strive and bring the intensity much forward, take it on and engage much more in depth, and have much, much better results in terms of how we take this forward. The challenges have always focused towards project timelines, budget, and definitely a strong cultural shift that is needed to take this work forward. And with this, I will stop. I have a few slides below this, which will be probably shared with all the participants at a later point, which focuses on some of the key things that we have done: the EDI framework at the Central West OHT, the EDI charter, the EDI terms of reference, and I believe we have the key concepts from the action plan, and also some of the key highlights from the leadership diversity survey. Thank you so much. It's been a pleasure sharing our journey with you, and I hope to continue learning with everyone. These are just some slides that talk about the different things that you might want to have a quick look at. Thank you.
Thank you for sharing, Aju. And I will just go through the slides that might really be of interest to our participants. So the Equity, Diversity and Inclusion Action Committee responsibilities and terms of references. So remember, you can always download this presentation 1 week from now. It's going to be available on our HSPN website. So you can always get this, but if if you've forgotten how to get it, please just email us and we'll be able to share this with you. So next, it's the Central West Equity and Diversity Inclusion Framework. So I've seen a lot of people have been asking, like, is the framework available? Like, are the equity charters available in the chat? So these are some of the appendixes, the resources that might be available for you. And as I say, it's going to be available on the website in about 1 week's time. The whole presentation, all of our 3 presentations, including these resources. So he's also included the vision, the goal statements, and the focus. That's for the Central West OHT EDI. That's the EDI charter. So I think this responds to Ethel's question that was asking the EDI framework and the charter. If it's so I wanted to know, like, Aju, do we have this? Is it published? Because it seems as though a lot of people are asking for, like, people want to have more information about, like, what is actually going on. What are these tools that are available? I saw one comment asking if they had shared a repository of shared tools, and I want to know, like, your ATI framework and charter, are they available online? Can you share a link, or are you willing to share with us so we can share with our respondents?
We can happily share the EDI charter and the framework with anybody who would like it. So we can even send in. What I have done on the slides is, like, just highlight the key pointers from the EDI charter and the framework. And with the leadership diversity survey also, this is something that we have gone through, we have published. It's only the action plan that I have highlighted in the next slide, which has not yet been approved, but we're tabling it with the Collaboration Council this Friday, and it should be done. So by the timeline that you mentioned for the next week, I think it should be already approved and published by that time. So if anybody is interested in accessing the entire resource as is, I'm more than happy to share, but I believe the key concepts from each of it. The framework is as is the EDI charter. You have the key commitments that everybody signs on when they are joining the Central West OHT. So it gives you that they are the key pointers. Like there is a lot of other wording text that comes with it, but the commitments is the most crucial part. And the action plan, this is what we are focusing on. This is our next journey. Like the action plan is really from where we derive our work plan, and we'll take the journey forward in this case.
Okay. Oh. Thank you very much for sharing this, for sharing your stories. So I want to really thank Janelle, Ajo, and Mirna for sharing the stories of the Mississauga, West Toronto OHT, and the Central West OHT. So before we actually go to like our open conversation, I wanted to know to hear from you, the participants, like what conditions or factors have contributed to strengthening your capacity for equity-oriented work. So building from what we heard from our presenters and your own experiences, like, do you think like factors like external facilitation from consultants or investing in building human resources like hiring an equity coordinator, maybe like funding, was funding critical, or internal or external funding to advancing your equity work? And what about senior leadership, their commitments and their engagements in advancing your work? Was that really important? Then the availability of guidance documents of terms of references, I think this has really been raised up here. People want to actually like see what others are actually doing in terms of their charters, the AGI frameworks, and also working with community partners in order to advance the equity work. And if none of those factors was actually listed here, maybe you can actually share us maybe some other factors that you think has been really instrumental in helping you advance your equity work. So, okay. I mean, this is really consistent with organizational literature. We see that commitment of senior leadership is really about 36% of our respondents highlights the commitment of senior leadership as being very instrumental in terms of advancing the equity work. Then also working with community partners really comes in second. About 25% of our respondents think that working with, so engaging with the community sector has also really helped in building that capacity to advance this equity work. Then having security funding. So funding came in third, and external facilitation from consultants would help in to build the capacity in the different OHTs. Then let's see in the charts. Oh, okay. Oh, yeah. Emily says that the poll number 3 would allow only a single choice. So some people actually had multiple choices. We will rectify that next time. Thanks for pointing out, Amy. So if you have any other factors that you really think within that was really specific to your context and that was really instrumental in advancing equity work, please share it in the chats, and we would like to learn from you. So having completed this chat, I think we have heard from 3 great speakers about what has been happening in the OHTs, and we want to, from what we gather, were in their OHTs. When I actually hear the stories of Mississauga, West Toronto, and the Central West, I see that there was a catalyst in each of these, and in Mississauga was really the COVID that actually served as a catalyst because of the inequities that were observed during the pandemic, while in the Central West, it was this movement for social justice which is associated with the Black Lives Movement and other movements of social justice that really served as a catalyst for equity work to advance. Then in the Mississauga, West Toronto, the priority population there was really the Black population. So they actually focus on anti-racism approach. Meanwhile, in the Central West, they focused on older adults living, experiencing frailty. So two different kinds of population, but then instead of actually sweeping wide, they focus on one single population and then they build capacity around around that. Then I think senior leadership commitments occurred across both OHTs, and we also saw like external facilitation trainings of leadership training that were really important factors. So we want to hear from you, like, how are you building the capacity to measure equity in your own OHTs? Who is involved in carrying out this equity work within your OHTs, and what resources do you have to support the equity work from your OHTs? So we really want to hear from you. Is it similar to the stories of West Toronto and the Central West OHTs? And if so, and if it's different, what are those factors that really contributed to advancing equity work, or what are the challenges that you face in your own OHTs? So we really like to hear your stories from the chat. Like yeah. So Jennifer says, can any of the presenters comment on whether provincial health equity plans were utilized to guide your work? Oh, yeah, that is really interesting, because last presentation we shared the OH equity framework, the Ontario Health Equity Framework, that was produced in 2020. So I think I will start with Janelle, and then before going to Aju. Like, Janelle, do you think any provincial equity plans will help to guide your work, or was this approach really bottom up, really from what you felt in the field that you helped to shape the way your equity work was done? Janelle?
Absolutely, thank you. So I was actually just typing in the chat that I think it's a little bit of both, and I can't speak to how things were at the inception of the group. I can speak to how it is now. So because many of the organizations involved in this work do receive funding from various levels of governments, it is important that the work that we do align with the work being done by these levels of government. So, and we're also not trying to reinvent the wheel, and often there are working groups and tables that are doing some pieces of this work. And actually, there are members on the working group who have that decision-making power and have access to those various groups. So we are definitely not operating in isolation from provincial health equity plans or any health equity work that's happening at any level of government. And at the same time, the grassroots approach is also very important, because at the end of the day, we serve communities. So even though we do strive to align our work with what's happening at the provincial level, it is very important for the voices of the clients that our organizations serve to remain audible throughout the work. So I would say we try to strategically position ourselves in both. And the other piece with doing ABR work and many other pieces of health equity work is that the staff doing the work are also implicated or impacted by this work as well. So I think from that sense, there is more of that grassroots nature approach in some cases, because it is important for us to make sure the voices are represented. So hopefully that answers that question.
Thank you for sharing, Janelle. This is really helpful in understanding how you navigated the ministerial or OH plans, and also combining with the grassroots priorities. So what about Aju or Milna? Do you have to share in terms of like how the health equity, provincial equity plans shape the way you carry out your work?
I could take that one.
Please.
So the Central West OHT equity framework was based off the Ontario Health Framework itself. So we see that there are 11 pointers, key aspects that were focused in the Ontario Health Framework, and there were like definitely we borrowed very strongly from there. But at the same time, when that framework was being developed, the EDAC was having a very strong dialogue for the last couple of months where they had prioritized equity work. And then they highlighted that it cannot be only focused on the OH mandate or the plans according to that, because we have a very unique population. Like if you look at the slides that I've shared, I've highlighted that our leadership has 50% visible minority, which means, and when we compare it to our population, it is 70%, more than 70% of our population identify as visible minority. So there is a focus that we bring, take and adopt from the Ontario Health Equity Plans. But at the same time, it needs to be tailor-made to ensure that we are able to cater to our population, our community, and we are not losing out on those focus when we are defining programs, co-designing programs, and we are engaging with them. And even the leadership diversity survey was a step towards that, and to ensure that we are catering to our population that we are serving, right? If we have the ideal leadership, then we will have that ideal representation over there. But at no point are we losing sight of what Ontario Health or the provincial government is taking forward in terms of the specifics of the equity plans that are there. They form the structure and the foundation, but we are really building on that to take this work forward.
Okay. Thank you very much, Ajul. So mindful of time, we have about 5 more minutes, so I would go towards the last poll. We want to have a sense of if our webinars are actually meeting your needs. So the question is, after this webinar, is your knowledge of today's topic, like on a rate from 1 to 10, do you think it's you need more information, or if you have gathered, if you have actually benefited from much more information from this particular topic? So this will help us recalibrate and also focus on the topics areas in the next webinars. And you can always reach us. So let me see in the chats. Okay. Yeah, thank you, Jennifer. So while this poll is also going, we were also talking about the next webinars. The next webinar will be on the 27th of June. That is measuring equity. I think I can change this while you're actually carrying out the next poll. Yeah. So the next webinar is going to be on the 27th of June. We want to focus on understanding how the equity is being measured in order to improve quality improvements and assessments of equity measures, and how it's used to improve equity-oriented practices in Ontario health teams. And then the last webinar is going to be in July 25th. That is addressing inequities. That is, what are Ontario health teams doing in order to address inequities in their populations, their attributable populations. And we also had, in the chat, there were some questions about what do we know about Indigenous communities. And I'm very happy to hear from Indigenous communities and those that are willing to share their stories. And we'll be reaching out to some of you, and hopefully we're going to have much more information over the next webinars. So we are happy. So for the results, like for the last poll, like more than 3/4 of you actually think you've actually gotten some sort of information from these particular webinars. So write us, let us know exactly what are your needs, so that we should be able to adequately address them in the upcoming webinars. We'll be happy to integrate your perspectives. And also, you can also share some of your feedback just by scanning in this barcode, and also clicking the link in the chat in order to share your feedback. And thank you for participating in this webinar. you can share across all of our different forums, be it on Twitter, on the YouTube, and OHSPN.ca. Reach us, share the webinars when it's going to be available. So thank you. Have a nice day.